deputising for Russell this afternoon. Welcome to our July meeting in public. It's a meeting in public, not a public meeting. It follows a workshop session this morning where we've looked at our current allied health professional workforce and initiatives to recruit and the success that we've had there, which was really great to actually hear. Also, a number of improvement initiatives in the way that we work, and we also undertook some board patient safety training. I just want to say to the public that the board relies on the work undertaken by our quality and audit committees and also our finance and performance arrangements. These groups undertake robust challenge outside of the board, and I'd like the public to understand that as we consider each of the reports here today, which are all open and transparent, and we record actions that are put in place. Our responsibility as a board here today is to be assured around the quality, safety and experience of our patients and our staff, and to ensure that actions being taken to improve where that's necessary. And in this connection, I'd like to just acknowledge those areas where we know we're not at the standards we'd like to achieve, and to say thank you to all of our staff who strive to deliver every single day to improve. With that, I just want to say we're making a small change to the agenda items, the way in which we run the agenda due to commitments of some of our presenters. And so we will take agenda item 10.1 about revalidation before our performance elements of the agenda. Other than that, we'll revert back to the current format. So in terms of apologies, we have Russell, Glenn Burley, Jenny, Anil, Catherine Free can't also be with us today, and Robin Sneed will be deputising for Catherine for those areas where she's taking the lead. We're quorate. Any new declarations of interest or around this agenda? Simon.
Thank you, Chair. Just have to declare that my period of acting arrangements at LLR ICB as the Chair have come to an end, and I've let the Board Secretary know that.
Thank you. Thanks very much for that. Okay, minutes of the public board meeting held on the 4th of June. Are they a true record of our discussions? Any amendments? No, happy to approve. And then we move on to the action list. From where I can see, they're either future dates or complete or on the today's agenda. There's just two areas I'd like to just check in on. Is there anything else around electives and agency that's not in the IPR?
No, Robin will update the latest numbers on the ERF as we get there.
Okay, thank you. And Naj, any update on being able to get discharge data at the weekend?
So working with the informatics team to just work to sort of get that information. So it's still work in progress, Julie.
Okay, thank you. Thanks for that. So we've got various elements of the agenda this afternoon. The first part is around our strategic section, and we have the Chief Executive Report produced by Robin, but presented. Sorry, Natalie, I missed you.
That's okay. I'm sorry, Julie. I was slightly late with my hand. Just going back to the list, action list and matters arising. In point 24993/03B, we were talking about freedom to speak up and being included in the safer staffing report that I produce. That's still going to be the case, but not on all elements of quality and safety. It will be about any concerns raised about the nursing or midwifery staffing levels. What we proposed at this morning's board development was that any areas of freedom to speak up with regards to quality and safety would in future go into the IPR report within Naj and I's section of quality and safety.
Thanks, and thanks for that update. Something we agreed this morning, and it will be a monthly update as well in that respect. So thanks for clarifying, Natalie. Okay, and with that, I'll hand over to Robin.
Thank you, Chair. So I'll try and do Glenn's report justice. As always, he starts off really positive, and we're starting with some good news around the trust being selected for a silver award in the Ministry of Defence Employer Recognition Scheme as a supportive employer advocate for people in the armed forces community. And Glenn has also pulled out in the paper a special thanks to Gemma Davis for leading on the work on behalf of the organisation. So a huge thank you to Gemma for that. Against a backdrop of financial national deficit position of around about £3 billion, the incentive plan's been worked through for systems to achieve their agreed financial plans. This will have different impacts for each of the 4 trusts in the group, and although this isn't a foundation group board, it's worth noting. But although for both George Eliot and Swift forecast financial break-even positions, however, as the Coventry and Warwickshire system as a whole is not submitting a break-even position, then this will most likely mean that as a result of that, Swift and George Eliot may well miss out on further capital incentives that are released through such schemes. But that's all yet to be confirmed. But again, looking like that will be the position. Similar to payment by results approach, this type of arrangement can be seen as not giving money to those who need it. But as Glenn writes in his report, he remains of the view that this approach does incentivise organisations to become more productive. And as we know, that's a key element of the NHS plan going forward. And it's something we should all be really focused on, being the most productive we can with the resource we've got. Then Glenn's view certainly is that that remains a robust approach moving forward. In terms of urgent and emergency care activity, we know this is always a key element that we remain focused on and improving our performance, as we know that the emergency access standard is proven to be linked to reduce mortality and improve patient and staff experience. So we've got to obviously maintain our focus there, and we'll come on to more of the detail in that in the IPR. And it's further supported by the integrated hospital and community services model, and a useful reminder that the best solutions to flow problems often sit with our partner organisations and not just something we would resolve internally. So again, that's pulled out in the paper. Glenn goes on to talk about the pathology network and the work Lord Carter set out 2 decades ago. I think Glenn references and underlines the principles that still hold today. And in essence, where that's led us to now is for discussions to create a South Midland pathology network, which will effectively look to replicate the work done across Coventry and Warwick and amalgamate with Hereford and Worcestershire ICB system area. So again, that is a piece of work that's ongoing, and we believe that approach should see benefits for patients and savings to the trust. So again, we'll be part of those conversations going forward, and further discussions on that will be held at Foundation Group Strategy Committee later this month. So we'll give further updates as we go. In Glenn's paper, he always focuses on a directorate to give a key update, and this month is we've got an update from the Women's and Children's Directorate. And there's so much going on, so much good work going on in our Women's and Children's Directorate. There's an acknowledgement of the recent CQC good rating for maternity services going back to November 2023. There's full compliance against CNST standards and a 91% compliance against Saving Babies' Lives version 3 guidance, which again is a significant effort from the teams to achieve. As well as award-winning bereavement care for maternity and neonatal services. Our stillbirth rate remains really low at 2.35% per 1,000 births, and against national expected rates of 4.2%. So again, really good work there from the teams, and showing that all that safety work really does pay off. The estates work's ongoing in maternity theatres. They're on track to finish later this month, and likewise the refurbishment of Drayton wards also on track for completion early autumn, which again will improve the working environment and the environment for patients and care of expectant mothers. There's been further investment on top of all of that good work. There's been further investment into Women's and Children's Directorate recently, that's enabling them to work up plans to create a combined early pregnancy assessment unit and gynae assessment unit, creating a dedicated colposcopy and hysteroscopy workforce, and to create a dedicated cancer nursing team structure, as well as the additional appointment of 3 new gynae consultants that have now been recruited. And we've also successfully appointed the Trust's first modern matron in gynae services. We're also fully recruited at consultant level at paediatric and neonatal services, and also gaining excellent feedback from a recent ICB assessment visit in terms of delivering care to critically ill children. So again, all really strong work from the team, and that's all supported by strengthened directorate leadership structure that they've worked on and we've invested in to ensure that those improvements continue. So really good work and well done to the Women's and Children's Directorate. This morning at our workshop presentation, we talked about the advancements in allied health professional careers and the good work that we've done across the organisation. And George Eliot's now hold 2 really successful careers events that have attracted over 80 potential students from our local community, as well as a real focus on those allied health professionals and trainees that we have with us in how we attract them into substantive roles in the organisation. So a huge amount of work's been done there. And the result of that is that our current vacancy rate for AHPs is now down to below 2.5%, which is an extremely low figure when benchmarked nationally. So really good work going on across all areas of the organisation. And I'll pause there for any comments, Julie.
Thanks very much, Robin. That's really set out a really good areas of improvement within the Trust. Any questions or observations for Robin? No, I think you covered everything. Oh, Jackie.
Thank you. Yes, just a very quick question from me. Thank you, Robin. It's regarding the capital. I think you referenced it a couple of times in the commentary. What impact do you think the possible restrictions around capital allocations might have in terms of the programme for George Eliot?
Hack, do you want to come in on that?
Yeah, so I'll cover it in the capital Q1 report a bit later on, but I guess in terms of headlines, we've got sufficient capital in terms of maintaining our estate and being able to replace any equipment that's end of life. So there's not an immediate risk. I think this is more about investment in the future, and particularly in some of the things we'd like to do in the estate strategy, which we will be bringing back to the board in a future meeting. I guess the other bit as well, digital investment as well, but a lot of the digital investment these days is certainly in software is revenue funding rather than capital, but there is particular, I think cybersecurity is a particular issue, but we have had over the last couple of years significant funding nationally to support with cybersecurity and hardware as well. But we do also have Innovate, which allows us to fund our capital investment in our IT through a different route as well.
Thanks for that. Thanks, Jackie. And Hack, when we get the estate strategy, we'll be able to see how our funding streams will allow us to deliver that. Okay, thank you very much. I've got no other questions. Personally, like on behalf of the board, to thank the great work done by Gemma Davis too. It's a real great recognition, and it's also really good to hear about the improvements in women and children's following that CQC good and the continuation of that journey. So with that, we'll move on, and it's your part of the Natalie and Naj part of the agenda. First of all, Natalie, with you, report on safe nursing, midwifery and allied health professionals.
Thank you, Chair, and I'd like to take the report as read and highlight a few key areas. So within nursing, midwifery and AHPs, our vacancies overall have reduced. There are some areas with a higher percentage, which in the main are due to a couple of reasons. This year we undertook a big piece of work, and it is mentioned in the paper of the acuity and dependency, of alignment of our establishment with the actual budget, so that we required for the safe planned rostered numbers. So that has meant that there has been an uplift in establishment, which then translates into the vacancies being increased at the moment, but we are recruiting into those. And also with our new ward areas, we know that we've been able to open our new wards, which obviously require a workforce to run them and to look after our patients safely. So again, that's why we've seen a few areas with an increase in the vacancy. Our healthcare support workers we highlighted last month, and on this month's paper you can see that the percentage is higher than it has been if you look back over a few months ago. And following a deep dive into this, we really wanted to look at our attrition rate. Did we have an issue with leavers? And actually what we found is that our attrition rate is pretty static. We have leavers in our healthcare support worker group of about 3 to 5 a month. But we're still looking at those and looking at the reasons why. Have we got the right support in for our healthcare support workers? They do an incredibly hard job, and we need to make sure that we've got the onboarding of those new recruits in place. So we've plans to increase our recruitment process. We do a bulk recruitment for our healthcare support workers, so we can ensure that they come in and that they're trained and that they have their care certificate whilst they're on the new wards and into the ward areas. But we will obviously keep an eye on this. I am glad to say that we had an open day last weekend, and we have already recruited 20 new healthcare support workers, and we have another 30 in line for interviews. So we know we can get healthcare support workers in. We've just got to make sure that we retain our staff. The reports are also here to ensure that we have safety and looking after our patients. And we describe within the report the extra capacity areas and the number of times that the trust has needed to corridor nurse in ED or to board patients because of the challenges that we're facing with the demand on our services. And I just want to reiterate, and I know we brought a paper to the board a couple of months ago about how we safely and effectively care for these patients, that we do put in the extra staff where required. And we also do a comprehensive risk assessment for each of these patients that are extra, particularly in the corridor or boarding, as I mentioned. And we do duty of candour regarding the requirement to board for our patients. And as soon as possible, we are making sure that we de-escalate and ensure that we get our safe discharges and that we're able to move the patients back into the designated bed space. That said, we have had no patient safety issues in the month of the report, no red flag incidents regarding safe staffing levels, and we do a comprehensive look each and every day, at least 2 or 3 times a day with the corporate nursing team to ensure that we have the safe staffing numbers across the organisation to deal with and to look after our patients as demand dictates. And I think the other thing to mention is that we're continually reviewing our staffing levels, our recruitment and our retention, our rosters, and looking to reduce our temporary staffing usage to ensure that we have permanent staff with us that will develop and learn and undertake the ethos of excelling at patient care. I think that was it, Julie.
Thank you, Natalie. And this report is scrutinised by Quality Committee, Quality and Safety Committee. Any questions, observations to Natalie on this report? Umar.
Thank you, Chair. I just wanted to ask, thanks for that, Natalie. Really good to know that we're managing to attract the talent that we need into the organisation. So that's fabulous. It's really encouraging to also know that we're trying to find out why people are leaving. A lot of the time, organisations don't close that loop. So I think that my question is, what more can we do to make sure we retain those staff? Because the kind of cost of getting them into the organisation, but more importantly, of team dynamics and making sure the patient at the end of the day gets the best care, it's so important that we get that continuity. So what more do you think we can do?
It's a $64 million question, Umar, and I probably could wax lyrical for a long time on it. I think in the shortened answer, it's we need to learn through best practice. We need to learn through asking. So I think those exit interviews, those speaking to staff that are progressing or moving on, the reasons why, what could we have done? And it's actually getting in there first, having that earlier conversation through the one-to-ones, sometimes through appraisals, whatever option we have. If we have that soft intelligence that somebody is maybe looking to move on, what are the reasons why? What can we do? And then in the background, it's about making sure we have the right development courses for our staff so that they can progress, so that we've got succession planning, which is incredibly important. We've got that talent management programs on boards and ensuring that we've got it right. But most importantly, we need to ask our staff so that we get and can put in place the things that they want and the reasons why they stay at the George Eliot. We know that we have an incredibly good hospital that people want to work at, so let's keep it like that.
Thanks, Natalie. Thank you very much. Paul?
Yeah, just kind of an observation and kind of a question. So later in our papers, we have the IPR, and it talks about the loop we're in at the moment of unfunded beds, which in itself can create problems for how safe we are ultimately, given that it means that we're having to utilise temporary staff rather than permanently recruited ones. And it seems from that later paper that the crux of this is medically fit to discharge patients and moving them on. So just looking for assurance, really. I noted that sort of circa 60, but by the end of the month we were down to 49, or that sort of level. Will we continue to move in the right direction in terms of this? Because I know we've done some significant initiatives over time, but we can't quite get to a stage where they're business as usual, so they're not just working much harder to get people out, but we've got a process that enables that downward trend to continue.
Yeah, absolutely, Paul. And I know I saw Robin move forward, so absolutely, if I don't cover it off, I'm sure Robin will come in. So we do have a lot of working groups. We're working very hard and together with the ICS to ensure, and social services to ensure, that we do have the right pathways and that we've got early recognition of when people and our patients need support. So it's about looking at what will people need right at the beginning of their journey. So right when they're admitted, it's what planning forward, talking to the patient, talking to their families, ensuring that we've got the right processes and identification of the right pathway. We have lots of, for want of a better word, and I'm sure Robin will correct the terminology, task and finish groups throughout the organisation, but also with our external partners, making sure that we do have this process right. And then escalating if there's patients that are delayed. So we have a weekly meeting looking at patients who have a longer length of stay. So those that are at 14 days and 21 days, but the directorates are looking at patients even shorter period of time for that. And what have we got the right treatment plans? There's lots of work with red to green, we've heard before, about reducing the deconditioning of patients, etc., etc. So yes, we are working very hard to do that. We're scrutinising the numbers all of the time, and Robin and Catherine are absolutely talking to our partners about when our numbers are going up, what can we do?
Thanks very much, Natalie. Robin, did you want to come in quickly there before I move us on?
Yeah, we've Catherine and I have really got a grasp of this and are tracking down the system partners daily. As Natalie says, we've put in on the back of the collaboration event we did on the week commencing the 15th of April. We've also then looked at what business as usual looks like, which is what you're asking, Paul. And that business as usual has changed. So what we've got now, we've got a process in place whereby there's a meeting at 10:30 with system partners every day and a meeting at 3 o'clock every day. And that 3 o'clock meeting is to check that the actions agreed at 10:30 have been done, delivered, and what are they doing for the next day, and that planning for that next day. So the work we've done so far has absolutely influenced the business as usual. We have seen numbers continue to come down, as you say, but there's definitely more work, and also in the background in terms of funding some of those pathway streams in the background that Catherine and I are really trying to get to the crux of where the thorny issues lie. So as a system, we can address those open and transparently.
Thank you. Thanks very much. Thanks for the question, Paul. I'd just like to say it's a really detailed report, Natalie, but what you did in your summary was to bring that to life so that it actually gave us that understanding of the impact, but what we're doing to improve staff wellbeing, but obviously and importantly, safety and experience of care. And that led us on to Paul's question. So thank you very much. Happy to move on, and we're staying with you, I think, Natalie, to talk about that acuity review.
Yeah, absolutely. As the board are aware, it's a best practice and national requirement that twice a year, from a nursing and midwifery point of view, we undertake an acuity dependency and establishment review. The main review is generally taken later in the year, and we've done this purposefully so that we can align with budget setting and directorate development, service developments. So this report is the mid-year one, and really what it outlines is the extensive piece of work that I mentioned before that has taken place since the last review, which has resulted in the ward establishment budgets aligning with the planned safe staffing requirements. And this is in no small part to the collaboration working together of the finance department, HR department and the directorates. They've spent a long time looking and making sure that we have that alignment, which should mean that going forward there's no surprises, so to speak, and no requirements to say we need extra staffing. So I'm glad to report that in this one there's no immediate recommendations. What I have highlighted is a couple of areas that were mentioned previously, and this would be in a phased approach from the corporate nursing team, looking at areas such as the nurse in charge role and a requirement with regards to that and the benefits realisation that might bring, and also for the supervisory status of our Band 7 ward managers, which again has a lot of researched quality elements and safety aspects if there is a supervisory nature. At the moment, our Band 7s are 2 days in a supervisory position. If you look at the Royal College of Nursing guidance, then they support a full supervisory position for our Band 7s, but that would have to be over a phased approach. So I'm not proposing anything at this moment in time. It's just to highlight to the board that those proposals will be looked at in future. The other area, and it's not mentioned necessarily in the report, is to say that we have been waiting, and I know Lorraine's on the call, we have been waiting for an update from our Birth Rate Plus, which is an area that we undertake every few years with an external company with our midwifery staffing. And I'm glad to say that we do have that report back with us now, and so we are finalising, looking through those numbers. So in a future trust board, we will bring that to the attention of the board, but it's to mention we're not really envisaging any requirements from a financial point of view.
Thanks very much, Natalie. Questions, observations to Natalie on this report? No, I don't think you have. for me, it was an excellent report. Again, it's good to see that alignment with the budgeting process, something that we've talked about. I think we note about the nurse in charge and Band 7 supervisory element, and we'll look forward to receiving that. I just wanted to ask one question myself, which was around talking about building a case around outpatients. And I just want to be clear, will or could that then the benefits?
10 or 12, I thought that might be 140 there. Right, I better.
Sorry, Nudge. Sorry, you went on. You came off mute.
No, it's Vinod Patel. It's probably.
Oh, was it? Sorry, I could see your mouth moving.
Sorry, I'm on mute now.
Sorry, Vino. Will that actually improve the waiting list position? That could be one of the outcomes from that piece of work.
It could, Julie, yes. The acuity review will absolutely look at the activity as well through outpatients, and look at traditional versus, for want of a better word, modern ways to look at staffing. I think we have a very traditional methodology currently, and that's what we're having a look at to see, have we got that right? Are we able to increase our capacity and the amount of activity we can do through outpatients within the current envelope, or do we need to have a look at how do we do that differently? But yes, it will take that into account.
Okay, thank you very much. Welcome, Vinod Patel. There you are. I was looking at Nudge but couldn't see you. Are you okay if we take the next report and then I'll bring you in? Is that okay? Okay, thank you. So people are moving around the screen. Lorraine, I saw you earlier. Over to you on perinatal quality and safety.
Thank you. So I'm going to take the report as read. This is data for May. Can I just say it's really heartwarming and lovely to hear the start, the achievements in the women's and children's, and actually the amazing team that I have the honour of leading. So it was really good to hear it all, a synopsis in one place. So thank you for that. So no serious incidents to report in the month of May. We had no stillbirths, and actually our position is actually even better than in Glenn's report. We're 1.85 per 1,000 births now on the 12-month rolling basis, which is, as we said, is way below the national average of 4.2, and no neonatal deaths. So our rates are 0.46 per 1,000 births, which is again way below the 1.6. We had 2 ladies admitted to intensive care unit. We've done a full review of the care, no immediate concerns from that. But obviously, we've supported the families and looking at that, and that'll go through our internal patient safety forum to review fully, but as I say, no concerns noted initially. Our midwife to birth ratio in May was 1:27. That's again driven because our birth was slightly down in month. I think April we had a really blooming month for birth, so actually that's probably back within normal limits. And all our women had 1-to-1 care in labour. We're pleasing to see that our prompt training remains way above 90%, so we're at 96%, and actually mandatory training is above 95% across the directorate as well, which is great. Obviously, we did get full compliance for year 5 CNST, but year 6 is in full swing. Our initial gap analysis is looking like we should be okay, but there are a few areas that they have changed that we will just need to make sure that we've got full audits and evidence for. But at the moment, we're continuing to work through that. And I say, yes, really pleasing that we are now at 91% for Saving Baby's Life. And actually in Q4, we had gone up to 3 out of 6 elements, which is really pleasing. And I do say with that caveat that last 9%, it's going to be difficult for us to achieve because a lot of those that we put in the report are outside of our area of change really within a small DGH, but we're working with across the LMNS to make sure that we can put processes in place for us to get full compliance. The area that we've been working on is around our PPH rates and major obstetric hemorrhage. So we know that we had a peak in February and March up to 8.2% and 8.4%. We put a lot of immediate actions into place and a thematic review is in progress, and it was really pleasing to see in April actually we went right down to 1.5%, but actually in May we probably come to where we should be really around 4%, but that work is ongoing, sharing lots of information. We know that PPH rates is an international concern because the rates are up and there's lots of research undergoing with that. But obviously we continue to make sure that we've implemented that, and it is one of our PSERF priorities. So we've got an action working group and review every case. As we've said, our theatres are nearly there. So actually the workmen have finished. They are just going through their final revalidation checks and making sure that everything is normal and snagging is done. So that's really pleasing to see that those are nearly ready to be done. So lots going on, as we've said. Happy to take any questions on that.
Thanks very much. You're very pleased, and you can tell that you're very excited by some of the achievements there. That's great to hear. Questions, Sarah?
It's just a comment really to say that actually what we're hearing here is obviously a lot of hard work and effort gone in, and so right from the midwives and their assistants all the way through, a lot of credit there. But to give the board assurance, if any further is needed, that actually we do look at this in more detail in the Quality Assurance Committee, and we've seen probably really over the last 6 months a real rise in the level of assurance that we're getting in the quality of the maternal and the neonatal services. So I just wanted to bring that through, and also to make a comment on some of the system working. So whilst probably the sharp end is the wrong phrase, but whilst a lot of the metrics are at the delivery end that we're looking at, actually quite a lot of the maternal outcomes are related to things like smoking in pregnancy, diabetes, obesity, and the team within the George Eliot are working really closely with the community. So I just wanted to sort of plug that work as well, that I know is going on, because that is hugely important for people's outcomes. So whilst Lorraine is the expert in that as the non-exec, I just wanted to shine a light on the fact that there is that partnership work going on. Thanks.
Thanks very much. Sarah. Thank you very much, Sarah. Can I just ask one question, because there's a lot of positive, and you can hear the improvement, and Sarah's just testified to that. It's just that at the very beginning of your report, you talk about the number of data issues, which are 60, which could be alarming to our public. I just want if you could give some assurance about the nature of those and how we use them to learn.
Absolutely, and I can actually tell you those have halved already. So because obviously we've been doing a thematic review around major obstetric hemorrhage and looking at all our ATTAIN programme is where our term babies admitted to intensive SCBU or intensive care. We keep those datasexes open, but actually following our risk management discussion, we'd actually have closed those down, because we know we've already got a robust process of reviewing those. So actually we didn't need to keep those open, and we can just then add the learning into those datasexes. So that's why they were that number, but to give a reassurance, actually we've closed them because we've already got other meetings and processes to review those datasexes. So they were just a cluster of open incidents, but actually we have closed those.
Okay, thanks very much. Thanks very much for your report. Thank you.
Thank you.
Okay, we'll just take a bit of a break from the order of the agenda, and if I can bring in Professor Patel to actually talk about medical appraisal and revalidation. You're on mute.
I'll take the report as read. Thank you very much, Julie. And I'll just go through some of the highlights, and I look forward to any questions or queries. So the way that the revalidation and the appraisal system works is that we go by financial year. So we've had actually an increase of 26 doctors, and we now have 267 doctors to appraise. We've made 22 positive recommendations to the GMC, and there were 6 deferrals. We can actually tell you that there were no non-engagement notifications. So we have managed to get through to everybody, but there are certain circumstances that meant that the revalidation had to be deferred. And sometimes it was because we weren't able to get hold of their old appraisals, or they'd had a significant gap because they'd been abroad for 2 years, but there were always reasonably good reasons, rather than the fact that the doctor wasn't able to be revalidated. In terms of our appraisal completion rate, it's 84%, which is only 1% higher than last year. But we have a new mechanism in place, especially now that we have a manager, the very able Beth, helping us as well. And we have regular RAG meetings with our CMO, Beth, myself, and Ria. And if you were to look at the last 2 weeks' figures, the latest ones, then it's actually up to 95%. There are significant gaps in certain areas, like the PAs and the dental staff as well. But I think we've got a robust mechanism to start to sort that out. And we've also created multiple training events now. We've also had the people from the GMC come and spend about 3 hours doing the training as well, which was really helpful because the duties of a doctor and good medical practice did change somewhat, especially in relation to engagement with family and partnership working. So we're very pleased for that. So I think I'll stop there and then take any questions that you may have. I've got the report in front of me, so I can move to any part that you particularly want to ask a question about.
Thank you. Thanks very much. And thanks for coming in this afternoon to present this report. Questions? Observations? Nudge.
Can't ask him a question. I can certainly give an observation. I'm absolutely blessed having brilliant teams to work with, and one of them is this appraisal revalidation job planning team. Prof does a great job, and he's mentioned a couple of the others, Ria and Bethan. And you know, it is no easy task to keep doctors on the straight and narrow, making sure they're having appraisals, which then leads to revalidation, etc. And they are a brilliant team. They really do keep a track, and they do it in a really nice and positive way. So it makes my life, easy that I meet with them regularly, and they just say, "Yep, this you can revalidate this one, you can revalidate that one," and everyone's up to date appraisals. And even those ones that you mentioned about the physicians associates and the dentists, they're coming on board as well. It is, the new specialties that we're not used to, but we're starting to embrace them within the appraisal process as well. So it is an excellent, excellent improvement, excellent work by the team, and I'm absolutely indebted to them for all the hard work they do.
Thank you very much, Naj. Judy, can I come in with a comment there as well? That was very grateful for that observation, Naj. But one of the things that's coming across in the appraisals, because I do quite a lot, is that people are very, very positive about working at George Eliot. And I think that's a important thing to learn from the appraisals, that people do actually appreciate the support that they have from their colleagues and management as well. And I think that is a bit of a change over the last few years, which I think is very positive.
Thank you. Thanks for that observation. Thank you. Sarah.
Just a quick question. So on table 2, it talks about associate specialists, staff grades and specialty doctors, and the completion rates. And it was just to ask really, do we understand the reason the percentage is lower there? And we're just, I suppose for me, assurance that those doctors have equal access to the appraisal process, and that we're not being hierarchical in any way. Thanks.
No, thank you. I think it's a great question. And in fact, I was talking to a specialty doctor today, and one of the reasons why they have this slightly strangely lower rate is because they're also part of another appraisal system as well, but not SARD, not the official trust one. And what we have done previously is said to them, look, guys, if you're having appraisals there, you don't have to worry too much about SARD. But now we're bringing everybody onto a single platform. So I think there was some confusion before, but they do have equal access, and they're followed up with the same rigor as everybody else. Really, thank you.
Thank you. Thanks for that. And it's good to hear about the feedback as part of the appraisals, but also that 95% completion rate now. That's excellent to hear. I don't think we've got any more questions for you, but we can take, we've got an approval here to actually approve this, the revalidation part of the report needs to be approved. Are we happy to approve that? Yes. Very big thank you, and for all the hard work that Naj has quite rightly mentioned.
No, thank you very much for the opportunity. Thank you.
Good to see you.
Bye. Thank you.
Bye. Bye.
Bye.
Okay, we'll move back to the substantive agenda, and we're on 6.4. There's a word in here I struggle with actually pronouncing. I'd like to say EPRR, but actually we're talking about the National Core Standards Report for Emergency Preparedness, Resilience and Response. I have trouble with that word, but we should call it EPRR. Robin.
Yeah, well done, Chair. Yeah, it's not easy to get your tongue around that one, is it? It's a bit of a mouthful, and it's a bit of a mouthful of a document as well. I apologise first of all for a 38-page document coming to board, and ordinarily would look to ensure that papers are much more succinct. However, in this occasion, there is a lot of detail in here that where we've got a statutory responsibility to bring to board, and it actually forms part of our core standards that we do bring it to board for discussion and awareness. So this paper effectively sets out our position in terms of our emergency preparedness and response plans. So in essence, we've got a position whereby in last year, you'll remember me coming to board mentioning that we'd our rating as a dip to non-compliant, but our actual performance in terms of our planning hadn't changed from year on year. And the reason for that change in rating was because there was a new appointment to the regional emergency preparedness lead, who then revised the way the core standards were being reviewed and the expectations of the evidence provided, and some of which was a timing issue of over a period of time. You needed to have done certain exercises and produce certain documentation that it was almost impossible then to catch up on it in that time frame. So on that basis, what we've done is we've gone back and done a hugely comprehensive review of our emergency preparedness and resilience planning, and part of that is we've recruited a new emergency preparedness manager, and that's a lady called Nikki Dryden. And Nikki started work with us in May. And prior to that, we had a chap, Nick Farr, who was supporting us in pulling these plans together. And Nick's got a lot of national experience at emergency planning. So we've pulled on our experience and pulled together an extremely comprehensive plan as to how we effectively move ourselves from the 69% we were at in terms of our core standards representation through to the expectation of being above 97% and compliance in the by August this year, when we expect this year's core standards to be submitted. We haven't yet had the core standards form, effectively the template, to complete. We haven't been asked to complete that yet. We're expecting it any moment, but we thought it was worthwhile coming to board at this point to demonstrate the amount of work that has gone into preparing us for that submission. And on page 9 of 38, there is a timeline there that shows that we are on track for on our journey, and the 2nd of July today is represented on there for the policy or the report to come to this public board. I'm not going to go through all the details in that plan. There's a huge amount of details. I can say that the teams have worked very hard in terms of pulling this together, and we've done a number of exercises. Last month we did an exercise of a chemical spillage and patients presenting with chemicals on them, and that prompted our teams to put up the CBRN decontamination tent in real time. And so that exercise all went very well, and we did a hot and cold debrief on that. We've also done a couple of tabletop exercises as well with several members of the team. So again, all of that is enriching our approach to the unforeseen event of an emergency occurring in the local or national vicinity. And I won't go into any more detail, Chair. I will happy to take any questions.
Thanks very much, Robin. We did consider this at Audit Committee as well. Simon, did you want to say anything around that consideration?
Not at this stage. Thank you, Julie. I think Robin has covered it.
Thank you. Any questions to or observations to Robin? It is a significant report. It shows how a lot of work going on at the moment, which the board would absolutely commit to and support. And it was good we met Nikki as well, so it was good to meet as well. So the new manager too. So thank you very much. We received that. We move on to the performance element. We are running a little bit behind, so we're with a bit of help here. Remembering that elements of the integrated performance report are looked at with our committees and through our F&P arrangements. So if you could highlight specific areas around patient safety and experience. We've got some great performance, but other areas where we would like to do better. So Robin, I'll hand over to you. You're on mute, Robin.
I am indeed. Apologies. Thank you for that, Chair. Yeah, as we go into the new financial year, obviously we're focusing on all elements of our performance, as you'd expect. We continue to focus, as I've already mentioned, on increased productivity and collaboration with the teams to improve patient outcomes. In line with all trusts, we've seen high levels of demand for emergency services, and again, that heavily linked to what you say around particularly patient quality of care being delivered. But we have seen a marginal improvement in our 4-hour performance in May to 75.3%. It's not quite where we want it to be, and obviously we've said time and time again at this forum that our aim still is to achieve 95%, which is the original NHS target. So we still push to make improvements on that scale, and we're also pushing to see improvements in our ambulance handover performance, which obviously again is a key quality indicator for patients who are delayed in handover. But I can say that we've seen significant improvements in that area at the George Eliot, which is great for the patients and for the teams involved. In terms of our elective recovery performance, focusing on, again, patient safety and quality of care, of timeliness of getting elective services to patients, we remain on track with our trajectory plan, and throughout April and May gives us a good start into the new financial year. And we've reduced our total numbers of patients on our waiting list to just short of 16,000 patients now, which is the first time it's been below 16,000 for quite some time. And we still remain committed to having no patients waiting over 65 weeks, waiting longer than 65 weeks by the end of September this year. So that's still a key focus area for us. In terms of cancer performance, which again we've talked about at length previously, is in April we had a significant increase in the number of patients treated within 62 days. I'm pleased to report, was 67.5%, and this is the highest performance since August last year. However, I would like to pull out that we can expect to see this reduce again in future months as we treat the backlog of patients who've waited over 62 days. And as we treat those patients and they feed into that performance number, we see the performance drop. That's expected as part of our trajectory in order to be able to clear the backlog so that we can get back onto sustained good performance going forwards. So that is part and parcel of where we're aiming to be. Our hospital mortality reviews are all in expected ranges, which again is really positive. We've also seen key workforce metrics improve, such as mandatory training, sickness absence, along with a reduction in agency staffing spends, in line with our aim to reduce dependency on temporary staffing, which again has been mentioned earlier. We've seen a significant improvement in our staff appraisal rates following the move to using the My Learning system. And we've now broken through the 85% rate for staff having their appraisals, which is the first time it's been over 85% for a number of years. So again, a huge effort from all the teams involved to make sure that happens in a timely manner. We've already mentioned earlier around the financial planning. our financial plan has been submitted, moving us from the original £9 million deficit position to a break-even position. The plan does assume delivery of an ERF target of 130% of the 2019-2020 baseline, and also delivery of an 18.8 million CPIP target as well, which we continue obviously to put plans in place for delivery of that, and we monitor that rigorously and closely through our finance and performance executive meetings as a subcommittee of the board. After 2 months, we have got a deficit of £2.9 million, but this is in line with our financial plan, and we're reliant then on an improvement in terms of both CPIP delivery and ERF activity to be able to continue to deliver in line and improve that position to that break-even position. And as Hack referenced earlier on, I can say in May that our ERF activity was 127%, an early indicator, because I know Russell often asks. In June, our position at the moment was sitting at 129.4%. So again, showing everything going in the right direction, and we would expect that with the final elements of validation and an entry into the system, we would expect that to break the 130% mark for June, which would keep us on track with our financial delivery. Happy to take any questions.
Thanks. That's a great result, great trajectory there. Thank you. Questions for Robin? I think you highlighted the main points there, Robin. Thank you very much. And we'll move on to Hack, the Capital Q1 report.
Thank you. So we've agreed an operational capital allocation of £8.5 million for this financial year. But you'll note from the report that we're having to hold back £1.2 million, and that's because the electronic patient record system that has just gone live at UHCW has not been fully funded yet. So we're still working on getting some additional funding for that. So which is why we're having to hold back some capital just in case we don't get that additional funding. Our capital plan, you also note, is a lot lower this year than previous years, as we don't have any major building projects this year. The focus instead is on embedding the new ways of working that are being enabled by having by the investment that we have made so far in things like the Community Diagnostic Centre and the 2 new wards. In terms of the actual expenditure against our plan, so at the end of May we only spent about £400,000, but that was in line with our plan, and most of that expenditure is on our ward refurbishment programme. So I think for the first time in a long time we've been able to actually invest money in refurbishing our wards, and that's been enabled by having the 2 new wards, because we've been able to create a decant ward. So you can see some of the knock-on impacts of some of the investments that we've made previously. And as part of that ward refurbishment programme, we're also installing the TVs that have been donated by the charities. We're very grateful for support from the George Eliot Hospital charity, because that'll be a great benefit to the patients to have individual TVs installed alongside each bed. We've also got some changes to the capital programme already, and all the changes go through Trust Management Board. So you can see within the report £123,000 worth of changes that have been listed within that. So they've gone through due process, in terms of agreeing those and making sure that we've got the appropriate governance around any changes to the capital programme. One of the other things we're trying to do is make sure the capital programme is more evenly spread throughout the year. So we are working with directors to get the orders raised for as much of the capital programme by September as we can, to avoid a mad rush at the end of the year when it's the busiest time of the year. So that's one of the focuses of this year, is to get a more even programme, more even expenditure against the programme this year, to manage the workload for everybody across the year. I'll leave it there. Take any comments or questions.
Thanks, Hack. Comments or questions to Hack? Natalie.
It's a comment rather than a question. It's just about the refurbishment programme, and just a huge thanks to the Trust Board for supporting this programme. It's been well needed, and if anybody has had the opportunity to go up and be on our first older ward to be refurbished, the difference is phenomenal. So it's a huge thank you to the Estates and Facilities team for working out this programme, and it runs all the way up until the middle of October and gives us some well needed cleaning and changes and refurbishments to our ward areas. So it's just a really big thank you to be able to do this.
Thanks very much for that comment, Natalie. Can I, Robin, before I come in, Robin?
Sorry, Gina, I just wanted to sort of jump on the bandwagon there a little bit, really, and just echo that support for our estates and facilities colleagues. I think that as part of a couple of weeks ago, it was Estates and Facilities Week, and we, as an organisation, we had some various events around the site for our estates and facilities colleagues and for others to join in. And as part of that, which we've done now for the last 2 years, is that each of the exec directors has taken on a role with and gone and worked with our estates of facilities colleagues. I had the good fortune of going to work with our painters, who were redecorating the new wards, as Natalie mentioned. And I just would like to say, Naj and I, as part of that experience, got the opportunity to go up into the loft space and see the work that is going on up above the ward areas that no one would ever see, which is in the ventilation works that is going on to support new ventilation processes in those new ward areas. And it is phenomenal, the amount of work that is being done that no one will ever see or is unlikely to see. And I think it is just worth underlining that support for those estates teams who are working so hard in order to get the work done and completed in the timescales that we've set. So just a huge thank you to those.
That's great acknowledgement and recognition that comes from all the board. Thank you, Robin. My one question, Hack, was I don't think I caught in terms of holding back the money and the risk area. When will we be clearer about UHC? You're smiling at me. We don't know.
we don't know, and with the election as well, I think it's kind of it's going to delay things. So I think it's really hard to say how things will pan out post-election.
Okay, thanks very much for that. Okay, with that, we'll move on. We received and noted all of the areas set out in the recommendations of that report. Ratified policies, Robin?
Yeah, and keep this nice and short and sweet, Chair. There were no policies presented at the controlled documents group that needed policy review group ratification in May 2024. So the policy review group in May was stood down, so a nil return for this month.
Thank you, but we're assured by the process. Thank you. And then we spent quite a lot of time this morning talking about the board assurance framework and corporate risk register for Q1, or certainly the risk management arrangements. But Robin, over to you for this one.
Yeah, thank you again, Chair. So just quickly to note on the title sheet of this paper for factual accuracy, I did note one error, and it's on point A on the recommendations and the action required to receive and note the BAF and corporate risk register. It says on the paper 2023-24 Q1, and I believe that should be 24-25 Q1. So just noting that for factual accuracy. So the 2023-24 end of year BAF was approved for closure at the Trust Board in April, along with the presentation of the Q4 corporate risk register. Appendix 1 and 2 in the report sets out the Q1 BAF, as I said, for 24-25 and the corporate risk register for the same period. Both reports have been subject to scrutiny at a number of forums: the Exec Risk Committee, the Quality Assurance Committee, the Audit Committee, just underlining the level of detail that we go into within the organisation and the scrutiny policy, the process we take in terms of managing our risks. And the key points that the paper pulls out is that the BAF has been refreshed and reformatted in line with Trust strategic objectives for this year. We've aligned it with system risk registers. All the risk scores have been agreed with chief officers, and all BAF entries give substantial assurance, except for 2, which is moderate assurance, which is reduced waiting times and reduced bed occupancy. And there's detail against each of those BAF entries as to why that assurance level is different. BAF 9 is an additional risk entered around financial plan delivery, as we've already just spoke about, and BAF 7 we've split into 2, which is around the digital risk. We felt that now, as we head now towards our own EPR journey in terms of implementation, and we discussed at the last board around the development of taking that forward in line with the UHCW single instance delivery, that we felt we were at a point now this year where we needed to single out the EPR development with its own entry on the board assurance framework away from the other digital developments. There are 29 risks on the corporate risk register. Out of those, 23 are either extreme or high, for 4 extreme and 19 high to be exact. The 4 extreme risks they're identified there and linked back to the BAF entries, and particularly relating to industrial action, with particular reference to current ongoing industrial action with our medical teams, implementation of ambulance immediate handovers, with this is a national directive that has affected all trusts across the country, reducing bed occupancy and overcrowding in ED, and also our ophthalmology pathways that have been previously referenced. They're the 4 areas where we're demonstrating or we're noting extreme risk. Following best practice, it's been recommended through Quality Assurance Committee that we change the way in which we address our levels of assurance or document our levels of assurance from a 5-level system to a 4-level system. The details of this are in Appendix 1 for people's reference in the papers, but in essence, the 4 levels that we would propose to move to are full assurance, significant assurance, partial assurance, and no assurance. And we would therefore ask board to only receive and note the progress made in terms of the development of our board assurance framework and our corporate risk register, but also to approve the recommendations to move from a 5 level of assurance system to 4 levels as a principle to guide us through further development of the process. And happy to take any questions or comments.
Thanks, Robin. Again, we talked about it at length earlier. It has been through other committees. I think, unless anybody says to the contrary, we're happy to move to those 4, but we are going to make sure that we get consistency throughout the process. There were some comments made this morning in terms of definition of levels of assurance. Okay, happy to move on. Thank you very much. We come to that part of the year and the agenda where we're looking at annual reports. We've already received 1. We've now got a couple of others. And first of all, we've got medical education annual report. And I think we've got Louise with us. Harmer. Louise, are you there?
I am, yes, thank you. So this paper reports the activity and successes and challenges of medical education over the last year. It provides some positive assurance that medical education is being delivered successfully, and where we have challenges, there are actions in progress to address those. So we're asking for the report to be noted and for further support for development of educational facilities and faculty as we move forwards. We've had a little bit of a restructure this year, and we've now got clinical skills and simulation as part of our team as well. And that's working really well at the moment because they're involved in everything that we're delivering for undergraduate students and postgraduate trainees, trust medical staff, MDT staff. So innovation has been a really key part of what we've done over the last year. We are carrying out primary educational research. Our audit and QIP output is also growing. Undergraduates continued to deliver education for our Warwick and Leicester medical schools, and there's been continuous improvement in feedback and enhanced understanding of the student placements amongst the clinical teams, which has been really nice to see. We do have challenges, and that's increased placement requirements and complex timetable planning. And a lot of our students require wellbeing and neurodiversity support, along with cost of living pressures for them. And we've tried to support that through careful timetable planning and reducing parking costs, thanks to estates and the trust for their support with that. And we're also providing snacks and drinks wherever we can income generate through the team. Postgrad have continued to deliver for our trainees, and the number of trainees is growing yet again this year. There have been some recent changes in the team, and we've got a couple of posts still to recruit to, but that seems to be going in the right direction. We were disappointed by the GMC survey results in 2023, and we've robustly addressed that. We're having monthly meetings with the clinical teams and Chief Medical Officer and Managing Director. And at the moment, we've managed to address most of the concerns. We've only got 2 or 3 left that we're still working towards. Part of that work has really been about driving forward freedom to speak up and getting our trainees to tell us what their issues are and what it is that we need to fix. And that seems to be going quite well. We get a lot of footfall through the office, and they come and tell us when there's a problem. As you heard earlier, our Trust Postgrad team are delivering on the appraisal, job planning and revalidation agenda, and they're also supporting particularly our international medical graduates and our physician associate students from University of Birmingham DMU. The KEF and tutor team have continued to get great feedback, and that tutor team is expanding now. We've just appointed to a theatres tutor and a paediatrics tutor, so we're hoping that will improve all of our feedback. Clinical skills, Sim and TEL have also expanded, so medical education really has expanded quite significantly over the last year, and that's because of the requirement to meet all of the current and future needs for simulation delivery in particular. So in summary, the medical education teams have had a busy year. Feedback remains positive in undergraduate. We're working really hard to address any issues within the postgraduate feedback. Challenges, as I've already mentioned, remain the learner expansion. Although the new wards have supported placement opportunities, we will really need further expansion and investment in teaching spaces, sim, virtual reality and education faculty. Thank you very much.
Thank you, Louise, for setting out the hard work and the achievements of the teams, and for being so open and honest about survey results as well. It's really important that we're working to address those. Okay, we have 3 questions. First, Gertie.
It's not a question, Julie, but I think it's really important to thank Louise and all of the teams that work under Louise. I mean, Louise, your leadership has been fantastic. And this report really reflects the culture of George Eliot. We're really open about the successes and the challenges, the areas we're working on. I acknowledge, Louise, your continued disappointment, and I hear it about the postgraduate feedback. But I do want to reassure the board that Louise and the team have an exemplary action plan, that they are working really, really closely with colleagues across all of the trust to improve and to reflect the feedback. And we know that a number of the directorates, where we've seen of problems, are going to focus on sharing their improvements with the new doctors in training when they start in August. Naj has been really key in leading all of that work as well. But Louise, you and the team, undergrad, postgrad, the clinical education fellows and clinical skills, TEL, etc. Fabulous work, really well done. And if you would take our thanks back to the teams, that would be appreciated.
Thank you.
Thank you. I think we'd reiterate that, Louise. Naj.
And just exactly what Gertie said, same from me. A big thanks to Louise and all the team. They've done a fantastic amount of work the last 12 months. There have been challenges and there will continue to be challenges, but I have every confidence with Louise and the team. They always rise and come up with solutions. We are in a little bit of a transition. There are personnel that we need to appoint, but we have this real strong foundation of Louise and her team who are always there. They're the constancy in all this, and continue to give that sort of assurance that things are going in the right direction. So again, as Gertie said, a big thanks from myself, and continue to look forward to working with the team. And I think there's lots of opportunities coming up in the future, which as we'll be feeding back to the board as and when we make those improvements. So thanks to Louise and the team.
Thank you. I think you might be blushing, Louise. Simon.
Yeah, it's always a pleasure, Louise, to read this report. Absolutely a jewel in our crown in terms of the services that you provide. It's a suggestion, Julie. There's mention in the report of physician associates, and that's the second mention that we've had of those roles today. Yeah. And given the public interest that there is in the development of new roles, I wonder if we could have a paper to the board at some point in the future that specifically outlines what these roles are, how the students are trained, what experience they get, and what they go on to contribute to our patients. I just think that might provide a degree of assurance, given some of the wilder stories that are flying around.
I think that's an excellent idea. Simon will take that as an action, but Naj, do you want to respond to that?
I think it's a great suggestion. There's a lot of, as you've said, Simone, a lot of misunderstanding, misinformation around physicians associates. They are a really invaluable group of clinicians in our organisation. I can certainly say that here. And yeah, absolutely, I think it's a great idea for us to bring back to the board a paper just describing who we've got, what they're doing, and the absolute invaluable role they're playing in the organisation.
Thanks, that would be great to allay concerns, but also to be absolutely clear on their benefits as well. So thank you. Thanks for that, Simon. That's great. Okay, we'll let you leave, Louise, now before you burn up there, because I can see how nicely embarrassed that you should be. Well, not embarrassed. Thank you. Thank you for all the work. Okay, so we're now moving on, see if we can make Natalie blush. We're moving on to patient experience and volunteering.
Thank you, Julie, but it would definitely be Becky Millward, Jane Heatley and their teams that need to blush for this one. It gives me great pleasure every year to present this annual report of the great work that our patient experience, volunteers and support network do across the organisation throughout the year for us. We've tried to condense, because we could have run into hundreds of pages on exactly what they do over the year. So we've really tried to condense the report from an annual perspective. But I would like to officially thank Becky Millward, Jane Heatley and the teams for the incredible work that they're doing across the trust and in the community. And I think this report really highlights that it isn't only within the organisation, but they have been stretching farther afield and making sure that we've got that in community engagement and support. And this is my opportunity to also thank the charity who over the last 12 months had supported a pilot role, and we've now been able to make that substantive with our community engagement and support workers. And they are reaching out and making sure that we are taking and improving the care and reducing health inequalities, and making sure that we reach those hard to reach people and services and users, and getting to listen and hear from their perspective and what our future development and services should be. So we've been involving them in the developments and having an open and transparent communication with them, and taking forward our ethos of together and improvement together, and what we can do for our services. So our volunteers are an absolute best, and they have been recognised nationally for that in the past year, and we continue to be, as a trust, humbled by their commitment and dedication. And as I said, I and the trust are incredibly grateful for all that they do. So I'm happy to take any questions on the paper, but the accolades should go to Becky and her team.
So absolutely, if you can tell them where they were here, we would be giving them lots of recognition that would make them blush too, as nearly as much as Louise, I think. Any questions to Natalie around this report? Rosie.
It's just to really second what Natalie said. I attend the Back to Health Steering Committee, and what an amazing group of people, the work that they're doing in that committee as well to steer the activities. But actually my question's about page 4. There's a comment in there, feedback in the centre data. And there's something there about patients wanting better information around social care and help on discharge. And I'm just wondering whether that feedback goes to teams external to the hospital.
Thank you, Rosie. And it is a really critical point, because we know when we look at our feedback, whether that's from the patient survey, whether that's from complaints or it's from FFT, discharge is a very important area, and particularly our communication as such. So you'll note that we've set up, aside from the trusts groups, we've got a safe and effective discharge group set up, and we've particularly done that from an experience point of view. So that's where we will then be giving that feedback to the likes of social services, etc. What can we do to improve that? We have a complex discharge team that are really passionate about getting this right. And so they are liaising and collaborating. How much information have we got? Are there QR codes we can use? Are there leaflets we can use? How can we make it a little bit more user friendly, and to get that information out there, because it can be really complex. So this group is particularly there to look at the experience and how we can improve upon that.
That okay, Rosie? Thank you. Thank you very much for that report. We're now moving on to the closing parts of the agenda. We'll move to subcommittee chairs update, this time only from yourself, Sarah, on the 25th of June, which was only last week, wasn't it? Time's flying. And I'd just like the public to remember that we recall the assurance we take from the work of our subcommittees. So there's quite a lot of the reports that we've considered today that will have gone through your committee, but is there anything that you would like to add that we haven't particularly spoken about this afternoon?
I think if you just see in the report there's a couple of items that we've highlighted that we'd just like the board to be aware of. So the Clostridium difficile rates of infection and the ongoing work that is being done there. And also you'll see in the minutes, I won't labour now, but there's been the David Fuller review report, which we discussed, and we felt that we'd like to let the board know that we've asked for the learning from that to hopefully be looked at and applied across the organisation. And just to say, in the congratulatory mode of the different reports, I'm sure it will be being received at board, but we did receive the very first of the annual reports on nutrition and hydration, and that was really good to see. And that triangulates really nicely with lots of the other things that we were looking at alongside pressure ulcers and a whole range of things to make sure that patient quality and safety are at the top of our agenda. So those couple of things that you may see coming forwards in the future. Thank you.
Thanks very much, Sarah, and for the work of the committee. Okay, there's just a couple of sets of minutes to note or for information. And we're coming to we've made up time. So thank you very much for that. I hope that didn't stop anybody speaking. I don't think it did, because I know as a board you would have asked your questions. So I just want to move into any other business. I've got one. Any other business from anybody else? Paul?
Well, having listened to the BAF conversation, Chair, and where we got to in terms of agreeing the 4 levels of assurance, I think there'd be some real benefit if in each of the covering papers we receive for the board, where an executive opinion and assurance is given, is if we codified it in that way as well. So when I look at them, there's positive, the words positive, substantial, there's a whole different range of words that are used. And I think from a well-led perspective, there'd be some significant benefit if we referred to this 4-point assurance level that we've just agreed and use that on each occasion in our executive opinions. So, you know, it's not substantial, it's significant. It's not moderate, it's partial. And so we have that consistency in our language so that, you know, we can become accustomed to using those 4 words, no, significant, etc., partial, and so on. That I think would lead to some better understanding of what we mean collectively by assurance, personally.
Yeah, and some consistency in language.
Yeah, and consistency. Yeah.
Yeah. I think Robin's going to respond to that.
Yeah, I think that's an excellent idea, Paul, and I think that we can either include it in the exec assurance statement, or we can include it as a box on the title page of each paper that comes forward. So we can look at that. We can take that. I don't necessarily need to resolve that here, but we can take that away and look at that. But yeah, absolutely, that could and should be embedded in the papers.
Okay, I think Sarah, your hand went up, went down, but I think yeah, okay. Thank you, Paul. Thanks for that. Okay, my area of the business is I'd like to just take this opportunity because one of our board members, this is their last board meeting. So for Gertie, this is her last, and it's really nice that I've chaired this particular board, Gertie. So for me, I'm sure Russell would obviously want to have done it, but I feel quite privileged to be able to say a massive thank you, goodbye and good luck as Gertie is moving on to pastures new at Northern Care Alliance, closer to where she lives. That's her home. Thank you for the vision and direction that you've given to George Eliot, and also a huge personal thank you from me for the support that you've given me over the years. You have been really great and you will be missed. I won't make you go red. You can see how you are appreciated from the whatever you call them that come up on the screens. Robin, did you want to say something else before I absolutely make Gertie say something?
Yeah, just to echo those comments on behalf of the executive team, and I know Catherine would be saying exactly the same if she were here. Gertie is absolutely an integral part of the team, and she's great to work with her, and she will absolutely be missed. So thank you, Gertie, on behalf of the team.
Thank you, Gertie.
Well, it's not often you've seen me speechless, Julie. You have actually made me cry. I am so grateful for the time I've had with George Eliot, you know, to all of my non-exec colleagues who've helped me step into my first executive role, who've supported me and helped me develop, my exec colleagues who've just been stalwart, kept me going every day. I've been really fortunate to work with fabulous teams, and I get lots of credit, but if I didn't have the people and workforce teams, the education teams, the library teams, the OD team, I wouldn't have anything. I am lucky because I stand on the shoulder of giants, but it has been my privilege and my joy to be part of the team at George Eliot, and that's really obviously. You guys have made me cry. Thank you so much for everything. And this will be one of the roles I will remember fondest. But thank you all.
Thank you, Gertie. I wish you all the luck in the world. Thank you. Okay, with that, questions from the public.
We haven't received any directly, Julie.
Okay, if I can open to anybody that is with us in the audience today, if you would like to ask questions about what you have observed today. No, so we've come to the, I finished early. So I'd like to say a very big thank you to everybody. We are carrying on for the rest of the afternoon, and there is the AGM at 4:30 this afternoon. For those of us who are going into another meeting, can we reconvene at 15:40? Is that okay? Thanks, everybody.
Thanks.
Thanks, everyone. Thank you.
Thank you.
Thanks, bye.
Thank you. Good luck, Gertie.